بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين. السلام عليكم ورحمة الله وبركاته. Good day to everyone and welcome to the Pediatric Infectious Disease Virtual Research Day. Thank you for being with us. Thank you all participants, presenters, and everybody that exert effort to carry out this research day. I am honored to mention that this event is an opportunity resulted from the first collaboration between Saudi Pediatric Infectious Disease Society and Infectious Disease Fellowship Program Scientific Committee. Our program today will be graced by a total of 5 oral presentations and 6 poster presentations. The research and lecture, and also 2 lectures covering infectious disease and research topics that are essential to our service. We are grateful to our distinguished speaker, moderator, and panel of judges who are blessed to share their expert opinion with us today, and it will guide us to select the best research presenter. At the end, we are confident that the knowledge we will obtain from this event will be used in providing optimal patient care, and this may be the start of our new offers, allowing us to promote evidence-based research and continuous collaboration. Again, thank you all for participation. Enjoy the event, and we will proceed now to our program. We have 2 lectures. The first lecture will be presented by Dr. Imad Tleyh. Dr. Imad, he is a senior adult infectious disease consultant in Ohoud Medical City. He's pioneer and have a lot of experience in research. His topic will be formulating research question and hypothesis. Welcome, Dr. Imad, and thank you to be with us. And you can start now.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Thank you for having me on this program. I'll be sharing with you today some of ideas and personal experience on formulating a research question. So I cannot overemphasize the importance of asking the appropriate questions, as has been truly mentioned. It is not the answer that enlightens, but the question. What is good about the clinical infectious disease field, that there are a lot of opportunities to ask good research questions. And this research that we've done in 2010 was published in CID. We looked at the IDSA guidelines recommendations that have been published since inception of IDSA guidelines until 2010, and these guidelines included 4,182 recommendations. And as you can see from this graph here, 50% of the recommendations that were made by expert panels and different guidelines were based on level 3 evidence, which are low-level evidence consisting of either small case series, anecdotal experience, or expert opinion. So we have a lot of untapped opportunities, a lot of questions that we can ask and get very good answers that will guide our clinical practice. The same study has been done recently, was published in Ohoud last year, and I happen to be one of the peer reviewers for this paper. As you can see from this graph here, in the red bars, the majority of guidelines, again, 10 years later or 12 years later, are still based on low quality evidence. So only these minor proportions are based on high quality evidence. The bars in orange and gray to black are based on low and very low evidence. Now, before I start talking about how to formulate a research question, let me share with you some couple facts that I do believe in. The first fact is that discoveries do not happen suddenly, and they got inserted in the minds of rare geniuses, fully formed and ready to be disseminated. That's false. Discoveries happen in incremental phases, and so perfecting the knowledge that we have on any particular field of science and making only even incremental discoveries are very meritorious pursuits. So this encourages every one of us to pursue research, even if the discovery that we're going to make are incremental only in nature. Now, if you go back to the definition of research in the Oxford English Dictionary, it has very important keywords here. As you can see that I've underlined, they define it as creative work undertaken systematically to increase the stock of knowledge and the use of this knowledge to devise new applications. So there are few keywords here: creativity, systematic work, knowledge, and new applications. And if you compare the difference between creativity and innovation, so creativity is doing things that haven't been done before, whereas innovation is using ideas from a different purpose or application and applying it to a different field of science, so devising new applications. And it's a systematic work. So we always talk about systematic work and research. It's a field of science that requires researchers to have at least some basic skills to be able to undergo research projects. Even if they are not dedicated researchers, they need to have certain skills. Like any field of science, we cannot be physicians without going through medical school, cannot be pharmacists through going through pharmacy school, etc. So researchers need to have certain training to be able to do this work systematically. So where do research questions come from? There are a few sources of main sources of research questions. The first one is the available empirical evidence, or what is known as previously published research. So we start from where people have ended. So whatever research has been done, what is the cutting edge of research in a particular field? This is an extremely important source of asking research questions. Second is professional experience. So people who are experienced in certain field, expert in a particular area of infectious diseases, they know the literature well, they know the gaps in knowledge, they know what are the priorities of questions that need to be asked. So these people who are professionally experienced have, it's easier for them to develop or ask appropriate questions. And also in everyday's life, we all have questions when we see patients, and we go back to the literature or to references to see how to diagnose or manage or, give prognosis to our patients. So, knowing these resources, how can we develop a good research idea? You have to be knowledgeable. As you can see from the definition, it's all about knowledge. So to be knowledgeable, you have to really know the literature of the topic you're interested in pursuing. What is the cutting edge of the knowledge that of this particular area, so that you start where others have ended, you don't duplicate what others have done, and use your creativity and innovation. As we can see from the COVID research of the last couple of years, a lot of innovation has been made using medications from other fields of medicine, especially anti-inflammatory medications, steroids, interleukin-6 inhibitors, and so on, that are used in rheumatology and JAK inhibitors in oncology, etc. So using certain interventions used in other fields of medicine, translating it to medicine, the mRNA research that has been done previously for cancer research has been introduced into vaccine research, etc. And then you have to be open to feedback, review the research question with your peers, with your mentors, seniors, and refine it to develop a good research idea. Now, I'll be sharing with you a few examples of my personal experience here. This is an up-to-date card that I've written around 20 years ago, and it happened to, what elicited the question is what I referred to earlier as everyday's life experience. So, at that time, I had a patient who had pressure ulcer infection, and up-to-date wasn't online at that time. It was, just starting, and they used to ship to us CDs that you every 6 months get updated. So I went back to UpToDate. I couldn't find any references or reviews about pressure ulcer infection. So my mentor was a skin and soft tissue infection expert. So we decided to review the topic and and update what is being known about the management and diagnosis of pressure ulcer infection. And it keeps getting updated. Every 6 months we go back and update the chapter. So everyday life experience can generate research question. This important study again is based on innovation from other fields of medicine. I have this habit, and I encourage every one of you, and I know a lot of you do that. I follow journals, important medical journals, on a monthly basis, or for their titles and what is being published. And at that time, I noticed a very nice work done, published in JAMA, that looked at the American Heart Association guidelines. And surprisingly, as you know, the cardiology field is a very well studied field. There are mega trials heavily supported by pharmaceutical companies because there is a significant global burden of cardiovascular diseases. So investing into cardiovascular trial is good pharmaceutical company. So despite this, again, the recommendations based on the AHA and American College of Cardiology guidelines were the majority, 50% or half of them, were based on level 3 evidence. So, one of our astute physicians at that time, Abdurrahman Khan, he's now a fellow at Harvard. So basically he approached me, he said, I want to do some research. And I said, why don't we look at the IDSA guidelines, see what's going on? If the cardiology guidelines lack good quality evidence, what about our infectious disease guidelines? So we've done the study. So it's not duplication of the work, but rather it's extrapolating from other fields to your field. This is how you develop important research question. And, we found that 50% of the recommendations are based on low quality evidence. So what makes a good research idea? So are there frameworks that help us decide if our research idea is worth pursuing? I believe the FINER framework is a very nice framework, especially for junior researchers and people who just started their research careers, to use it to decide if the idea is worth pursuing or not. And FINER stands for a mnemonic for F for feasible, I for interesting, N for novel, E for ethical, and R for relevant. So when we talk about feasibility, it's different from one person to another, from one institution to another, from one setting to another. As you will see from the examples I'll be giving, there are questions that are really simple that we pose, even us as clinicians, not as researchers, we pose every day when we see patients, but they are not feasible for us to conduct. And when we talk about feasibility, we talk about time component. Do you have enough time to carry on this project? Do you have enough good infrastructure? So if you want to do a randomized trial, do you have the necessary infrastructure, the necessary funds? Do you have the appropriate number of patients that will make it an adequately powered trial? Do you have the appropriate knowledge and experience to carry on a randomized trial? So feasibility has multiple aspects and differs from one person to another. So a fellow who has only 2 years to complete a project cannot do a randomized trial that will require, multi-center collaboration and, 5 to 10 years of follow-up. So it has to be feasible for every particular researcher. It has to be interesting. You have to have passion about the idea that you're pursuing, not just because your mentor is interested in skin and soft tissue infection. You choose your interest, and then you look for your mentor. And you have to be fascinated about the topic and the idea. And then it has to be novel to have an impact. By novelty, it doesn't mean new, but rather it's something that is of incremental knowledge, and it's meritorious pursuit. So like the example I've given you, AHA have published, we looked at the IDSA guidelines. There could be studies that are being done in other patient population, but in our local population have different epigenetics and different environment. It may be worth duplicating. So novelty is not new always. It's novel, new maybe to your patient population, to your setting, etc. And ethical, although we think about ethical, that's basic, and we shouldn't worry about, we're not going to do unethical studies. You'll be surprised. I sit on the IRB at KFMC, and at many times I vote against approving certain studies which are full board review, like high-risk studies, because as simple as the investigators have not sample size calculations, so they're enrolling patient in a trial without doing sample size calculation. So you don't know how many patients you need to enroll, so you may be doing an underpowered study and exposing patient to unnecessary risk without adequately addressing the study. So it has to be ethical, and ethical component you have to make sure it's addressed from different aspects in terms of IRB requirement. And finally, it has to be relevant. Now, relevance to the investigator and relevance to the funding agencies, relevant to the career of the investigator. So if you're planning to go for transplant ID, you're not going to be doing neonate infectious disease research, for example. If you're applying for a grant to CACs and their priority is this year is TB, you're not going to submit a grant proposal about COVID, etc. So it has to be relevant. So this framework, I think it's a nice framework to appraise a research idea for every single investigator, feasible, interesting, novel, ethical, and relevant. And these summarize some of the things I've been talking about. So you have to be fascinated by the topic, to have the necessary research skills. You have to have the time available to complete the project. And very important point is the research still be current when you finish. For example, during the early phases of the pandemic, we had OB fellows rotating with us in adult ID because we had a large number of COVID patients. So we had PEDS ID, OB fellows, and adult ID fellows all joining the COVID service. So at that time, we wanted to look at the epidemiology and outcome of pregnant patients with COVID-19. And, the fellows were excited. At that time, there was only few case reports and case series, and the largest was around 100 patient systematic review published in CID, and we had a very good number of patients. But by the time the fellows started the project, we got the IRB approval, they collected the data, we analyzed it. It was very late. There are at that time multiple series and even a national cohort from UK published. So the impact of our research was minimal at that time. So you have to be sure your research is current when you finish. Then you have enough financial support, and you have to have access to data. So let's say you want to survey COVID patients, recovered COVID patient for long COVID symptoms. Do you have access to the MIH data? Do you have access to Hassan data, etc.? So all these things that you have to take into consideration when planning a research question. Now, research is a process. It starts with the research question, but it goes through certain loops here, as you can see from this diagram. You start with the research question, you conduct more literature review, and sometimes you modify your research question because of the knowledge gap. You could see there are no knowledge gap here, or there are more knowledge gap in this area, and then you refine your research question until you get to a stage where you can move on and put the variables and design the study and move on in the process. So what is formulation when we talk about formulating a research question? Formulation means translating and transforming the selected idea into a scientifically answerable question, which is the objective of the study. So you have an idea, you want to transform it into a scientifically answerable research question. And I cannot overemphasize how important it is to pose the appropriate scientific question, because it improves the clarity of the project. As you can see, you avoid problems during the design implementation of the study. You help address the validity issues and what literature you have to review, what resources you need, and you avoid waste and efforts. At many times people collect data without building a database, not for the purpose of a registry, but they're interested. I've had an astute resident interested in endocrinology, and he collected data about COVID patients who developed DKA, and they're only type 2 diabetics, they're not type 1 diabetics. And it's very unique data, because we had a very reasonable number of patients, unusually high. But, no clear question posed ahead of collecting the data. So by the time he came to me with a nice data set, but when we try to ask the appropriate question to address, you go back and you don't have these particular variables you're interested in. So there are wasted efforts, and then he has to go back to medical records and abstract certain additional data. So better to start with the research question to improve efficiency and minimize wasted efforts. Now, how can we formulate a research question? One of the nice framework is called the PICO or the PICO framework. PICO for the interventional studies, experimental studies, and randomized trials, and PICO for observational studies, cohort studies, and case controls. So PICO is a useful model. It breaks down the question into 4 key elements, as you can see here. You have the problem in hand, you define your patient population to be studied, what's your intervention, what's the comparator group, what outcome measures you're interested in, and then you write your research question and develop search terms for your literature review. So P stands for the population, patient population, I for the intervention, C for the comparator or control group, and O for the outcome. If you're doing observational studies, then it's PICO or P or PO. So P stands for this population, E stands for the exposure, C for comparator, and O for the outcome. So let me share with you 5 examples here from the recent presentation at the Soil Society in February. They asked me to present what I thought are the top 5 general ID papers that were published in 2021 with a focus on antimicrobial stewardship. So these are non-COVID, non-viral, only general ID papers. So I chose these 5 papers that were published in 2021, and we'll use the PICO and PICO framework to go over the research questions and talk about the final criteria also. So the first study is antibiotic therapy for 6 or 12 weeks for prosthetic joint infection, was published in New England Journal of Medicine. And the question is, in patients with prosthetic joint infections who are managed with appropriate surgical procedure, is a 6-week course of antibiotic therapy non-inferior to a 12-week course? So this is a very important research question, and in the adult infectious disease practice, we don't have an answer to this question. It's still based on expert consensus. We treat patients based on different guidelines, whether you're looking at the IDSA guidelines or orthopedic musculoskeletal guidelines. They have different time courses between 6 to 12 weeks. So it's an important clinical question that we have every day, but it may not be feasible for me or other researchers to carry on and answer this question. So it's not about the complexity of the question or how novel it is or how cutting edge it is. It's a very meritorious pursuit, as you can see, because it helps others think about it. Instead of keeping patients on IV antibiotic for 12 weeks, you cut it down by half. So a very important research question. If you take it, break it down into the PICO framework, the patient population are the patients with prosthetic joint infection managed with appropriate surgical procedure. The intervention is a 6-week course, and the comparative group is a 12-week course. And the outcome here, you're looking at non-inferiority, and you can define non-inferiority more in the method section. But what I want to bring also from this study is, when we talk about feasibility, this study, which is called the TIPO trial, it was between 2011 and 2015. So 4 years, it took 4 years across 28 hospitals in France to enroll only 410 patients. So around 12 to 15 patients per hospital. It took 4 years. Think about it. I mean, although it's a rare infection, but even in a smaller hospital, we do see maybe 10 to 15 years per year of at least prosthetic joint infections. So it took 4 years to enroll 10 to 15 patients across 28 sites in France. Thinking again about the final criteria. The second trial I presented was in Lancet, published in Lancet, discontinued beta-lactam therapy after 3 days for patients with community-acquired pneumonia and the non-critical care wards. It's a double-blind, randomized, placebo-controlled trial. So basically, again, you have patients who have community-acquired pneumonia admitted to the wards. You give them 3 days of antibiotic and they're doing great. And you wonder, should you keep them to continue the 7 days course, or can they be discharged safely to home without any more antibiotics. So it's a very important research question of everyday's life experience. But again, how easy is it for a researcher to carry on and do this project? If you look at the PICO model and pose the research question, in patients who were hospitalized for community-acquired pneumonia and clinically stable after 3 days of beta-lactam therapy, this is the patient population, is stopping therapy, and this is the intervention, non-inferior to an additional 5 days course. So the comparator group is the 5 days course, and the outcome is looking at non-inferiority. Again, this is the PTC trial. It took 5 years between 2013 and 2018, and it took until 2021 to get published, to enroll only 310 patients in 16 centers, so around 20 patients in each center, although we know that community-acquired pneumonia is a very common infection, and the numbers are much higher than that in every hospital. So it's sometimes logistics and the setting, the infrastructure, the support, the funds are important to guide what questions you pose. The third study was, again, a randomized trial, very important, published in JAMA, is effect of 7 days versus 14 days of antibiotic therapy, a resolution of symptoms among afebrile men with urinary tract infection, a randomized controlled trial. Now, there are a lot of randomized trials comparing short course therapy for UTIs among women, but I'm not aware that there are any in men with UTI. We always consider UTI in men as a complicated UTI, and we treat for 14 days. So this trial was the first of its kind. Could we treat these patients who are afebrile but who have documented UTI with 7 days instead of 14 days? So the question is, in afebrile men with acute urinary tract infection, this is the patient population, is a 7-day course of Cipro or Trimsulfa non-inferior to a 14-day course? So the intervention is 7-day course. The outcome is non-inferiority and the comparative group is 14-day course. This is a randomized study at 2 VA hospitals over 5 years. They enrolled 273 patients. Now, I'll end up with a couple of studies that are observational in nature, but again, I thought they are very critical to our practice, especially when we talk about stewardship. And this study was about inappropriate empirical antibiotic therapy for bloodstream infections based on discordant in vitro susceptibility. So, there are multiple small cohort studies and series in patients with different infection looking at associations of discordant empirical therapy with outcome of patient with hospital-acquired pneumonia. So let's say you admit a patient with hospital-acquired pneumonia, you start them entazocin, and after 48 hours you get the sputum culture and it's a resistance to Pseudomonas, so you switch to meropenem after 48 hours, versus you admit the patient, you start tazocin, and they have a susceptible isolate, and you continue tazocin. So these small studies have shown that the outcome of patients who receive discordant empirical therapy, even if it's changed after 48 hours, is poor as compared to patients who receive concordant therapy, even for the short 48 hours. So this has major impact on how we do empirical therapy for our patients. So this is the first study of its kind, and the question they pose is discordant empirical antibiotic therapy associated with higher mortality in comparison to concordant therapy in patients with bacteremia. So the exposure here is discordant empirical therapy, and the comparison is concordant empirical therapy, and the outcome is mortality, and the patient population is those admitted with bacteremia. Again, the strength of the study, it's a large cohort, 21,131 hospitals in the US, and 10 years cohort study. The final study is, again, I think it's a very important study that affects our clinical practice. We do practice this in the majority of patients admitted with invasive group A beta hemolytic streptococci, especially those with toxic shock syndrome or necrotizing fasciitis. We give clindamycin adjuvant therapy with beta-lactams based on animal models that show that they inhibit toxin production and decrease shock syndrome, and based on small series. So we don't have robust evidence to support this practice. And this study was the first of its kind, looking at the effectiveness of adjuvant therapy in these kind of patients. And it's not a randomized trial because it's a rare infection. So it's a cohort study posing the question, is adjunctive clindamycin with beta-lactam associated with lower mortality in comparison to beta-lactam monotherapy in patients with invasive group A strep? So the patient population is patient with invasive group A strep. The exposure is adjunctive clindamycin with beta-lactam, comparator is beta-lactam monotherapy, and the outcome is lower mortality. And the study again was a large collaboration between 233 hospitals over 15 years period to include 1,079 patients. So by this, I think I come to the end of my presentation. Thank you very much.
Thank you, Dr. Imad, for excellent presentation. If there is any question to Dr. Imad, maybe you can write it in the chat or...